Hello and welcome to our new topic. Today we will discuss the pharmacology of adrenocortical hormones, or corticosteroids, which are among the most widely prescribed drugs in medicine, and they influence nearly every organ system in the body. So, let's start. The learning objectives are shown. Please take a look. Hormonal disorders are best approached by identifying whether there is excess, deficiency, or dysregulation at a particular level of the axis, and then selecting drugs that restore balance accordingly. We will focus on two major groups of adrenal cortical hormones: glucocorticoids and mineralocorticoids. We will also discuss corticosteroid antagonists, steroid synthesis inhibitors, adrenal suppression, withdrawal syndromes, and practical clinical drug selection. This makes adrenal pharmacology highly relevant across endocrinology, rheumatology, pulmonology, dermatology, oncology, and critical care medicine. The adrenal cortex synthesizes steroid hormones from a single precursor, cholesterol. Despite originating from the same molecule, these hormones diverge into three major groups: glucocorticoids, mineralocorticoids, and adrenal androgens. From a pharmacological perspective, glucocorticoids and mineralocorticoids are especially important because we can manipulate their activity therapeutically. We may use agonists as replacement therapy, antagonists to block their effects, or enzyme inhibitors to suppress hormone synthesis. This slide shows adrenal steroidogenesis. Cholesterol serves as the common precursor for all adrenal steroid hormones. Through multiple enzymatic steps, particularly involving cytochrome P450 enzymes, cholesterol is converted into mineralocorticoids, glucocorticoids, and adrenal androgens. Notice that many pathways overlap. This explains why inhibition of one enzyme may affect several hormones simultaneously. The hypothalamic pituitary adrenal axis regulates glucocorticoid secretion. Stress, circadian rhythm, inflammation, and other stimuli activate the hypothalamus, which releases corticotropin-releasing hormone, or CRH. CRH stimulates the anterior pituitary to release ACTH, and ACTH stimulates the adrenal cortex to synthesize corticosteroids. The released glucocorticoids exert negative feedback on both the hypothalamus and pituitary gland. This feedback loop is clinically extremely important because prolonged exogenous glucocorticoid therapy suppresses the HPA axis. If steroids are suddenly withdrawn after chronic use, patients may develop adrenal insufficiency or even adrenal crisis. Glucocorticoids primarily support survival during stress by increasing glucose availability to vital organs. Cortisol is the natural prototype glucocorticoid. These hormones increase gluconeogenesis, mobilize amino acids, promote lipolysis, and suppress inflammation and immunity. Pharmacologically, glucocorticoids are among the most powerful anti-inflammatory and immunosuppressive agents available in medicine. However, these beneficial effects are closely linked to significant adverse effects, especially during long-term therapy. Glucocorticoids act through both genomic and non-genomic mechanisms. The classical genomic pathway involves cytosolic glucocorticoid receptors. After binding the cytosolic receptor, the steroid receptor complex translocates into the nucleus and alters gene expression. Non-genomic actions occur more rapidly and involve second messenger systems and signaling pathways such as NF-kappa B, prostaglandin synthesis pathways, AKT-enos signaling, and apoptotic pathways. These non-genomic effects help explain why corticosteroids can produce rapid clinical improvement even before major changes in gene expression occur. Glucocorticoids, being lipid-soluble, diffuse through the cell membrane and bind intracellular glucocorticoid receptors to form a receptor-ligand complex. This complex enters the nucleus and regulates gene transcription. Two major mechanisms occur here. Transactivation activates anti-inflammatory genes, while transrepression suppresses pro-inflammatory transcription factors such as NF-kappa B. This suppression decreases cytokine production, inflammatory cell activation, and immune responses. This mechanism explains the powerful anti-inflammatory actions of glucocorticoids. The glucocorticoid receptor contains several functional domains. These include regulatory regions, DNA binding domains, hinge regions, and steroid binding regions. The zinc finger structures in the DNA binding region are especially important for gene regulation. This diagram shows cortisol-induced apoptosis as an example of interaction between genomic and non-genomic pathways. Both rapid signaling pathways and delayed genomic mechanisms cooperate to produce the final cellular response. Clinically, this interplay explains why corticosteroids can affect inflammation, immunity, vascular tone, apoptosis, and malignant cell survival simultaneously. Glucocorticoids profoundly affect carbohydrate, lipid, and protein metabolism. In the liver, they stimulate gluconeogenesis and glycogen storage. In peripheral tissues, they reduce glucose utilization and promote lipolysis and protein catabolism. The overall effect is hyperglycemia, increased free fatty acids, and negative nitrogen balance. Clinically, chronic steroid therapy may therefore cause diabetes, muscle wasting, central obesity, and thin extremities. Glucocorticoids reduce lymphocytes, eosinophils, basophils, and monocytes while slightly increasing RBC count. They stabilize mast cells and suppress histamine release. They suppress cytokine production, inhibit leukocyte activation, and impair macrophage function. This results in immunosuppression and anti-inflammatory effects. These actions are therapeutically beneficial in autoimmune diseases, allergies, asthma, and transplant medicine, but they also increase susceptibility to infections. Glucocorticoids reduce T-cell activation, inhibit macrophage and dendritic cell function, suppress cytokine release, and decrease antibody production. They inhibit the production of pro-inflammatory cytokines, such as interleukin-1, IL-1, and tumor necrosis factor, TNF, while promoting the production of anti-inflammatory cytokines, such as IL-10, by macrophages and dendritic cells. They also promote apoptosis of macrophages, dendritic cells and T cells, leading to inhibition of immune responses. Clinically, these actions explain both therapeutic benefits and adverse effects. The same mechanisms that suppress autoimmune disease may also reactivate latent tuberculosis or increase opportunistic infections. Glucocorticoids induce lipocortin, which inhibits phospholipase A2. This prevents release of arachidonic acid from membrane phospholipids. As a result, both prostaglandin and leukotriene synthesis decrease. This broad suppression explains why corticosteroids are highly effective in inflammatory and allergic conditions. Compared with NSAIDs, corticosteroids inhibit both cyclooxygenase and lipoxygenase pathways indirectly, making them more potent anti-inflammatory agents. Corticosteroids affect many organ systems as shown. Take time to explore this table. Muscle wasting, psychosis, cataracts, and glaucoma are also important complications. These adverse effects become especially significant during prolonged high-dose therapy. This chart compares glucocorticoid potency and mineralocorticoid activity among various corticosteroids. Comer hydrocortisone, dexamethasone and fludrocortisone. Clinically, this difference guides drug selection. For example, dexamethasone is preferred in cerebral edema because it minimizes fluid retention, whereas hydrocortisone or cortisol is preferred in adrenal crisis because both glucocorticoid and mineralocorticoid effects are needed. At first glance, cortisol should strongly activate mineralocorticoid receptors because it binds these receptors with affinity similar to aldosterone and circulates at much higher concentrations. So logically, cortisol should dominate mineralocorticoid activity. However, that is not what happens physiologically. The reason aldosterone remains the dominant mineralocorticoid is the enzyme 11-beta-hydroxysteroid dehydrogenase type 2. This enzyme converts cortisol into inactive cortisone in tissues such as kidney, colon, and salivary glands. If this enzyme is deficient, cortisol activates mineralocorticoid receptors excessively, producing apparent mineralocorticoid excess syndrome, characterized by hypertension and hypokalemia. Glucocorticoids are adequately absorbed orally and may suppress the HPA axis even after local administration if exposure is on large surface area or prolonged. Most circulating steroids are protein-bound, mainly to transcortin and albumin. Some steroids are prodrugs. Prednisone is converted into prednisolone, while cortisone is converted into hydrocortisone, which is the other name for cortisol. This becomes clinically important in hepatic disease, where conversion may be impaired. Glucocorticoids are used in adrenal insufficiency, congenital adrenal hyperplasia, autoimmune diseases, allergies, asthma, and inflammatory disorders. In Addison disease, hydrocortisone is combined with fludrocortisone because mineralocorticoid replacement is also needed. In congenital adrenal hyperplasia, cortisol deficiency leads to increased ACTH and androgen excess. Glucocorticoids are also widely used in autoimmune and inflammatory disorders including rheumatoid arthritis, SLE, inflammatory bowel disease, and severe allergic conditions. Another important use is fetal lung maturation. Betamethasone is a preferred drug, administered before anticipated preterm delivery to accelerate surfactant production in fetal lungs. Usually, a tocolytic is used along with it to delay the labor for 24–48 hours to allow betamethasone to act maximally. Most corticosteroid adverse effects are dose and duration dependent. Long-term therapy may produce Cushingoid features such as moon face, buffalo hump, truncal obesity, thin extremities, easy bruising, hyperglycemia, osteoporosis, and infection susceptibility. Importantly, abrupt withdrawal after prolonged therapy may precipitate acute adrenal insufficiency. Therefore, tapering is essential after use for more than a week or longer. Many often confuse steroid withdrawal syndrome with adrenal crisis. Steroid withdrawal syndrome usually causes a flu-like syndrome such as fatigue, malaise, myalgia, and arthralgia, but patients remain hemodynamically stable. While adrenal crisis is a dramatic, life-threatening emergency. The distinction is clinically critical because adrenal crisis requires immediate IV hydrocortisone and aggressive fluid resuscitation. The low-dose dexamethasone suppression test is mainly used to screen for hypercortisolism. In normal individuals, dexamethasone suppresses cortisol secretion through negative feedback. Failure of suppression suggests Cushing syndrome. Low-dose protocols help confirm true hypercortisolism and differentiate it from pseudo-Cushing states. On the other hand, high-dose dexamethasone testing helps localize the source of hypercortisolism. Pituitary tumors usually show partial suppression because some feedback responsiveness remains. Adrenal tumors and ectopic ACTH-producing tumors generally do not suppress because they function autonomously. This table compares important glucocorticoids. Hydrocortisone is physiologic and suitable for replacement therapy. Prednisone and prednisolone are commonly used systemic agents. Methylprednisolone is preferred in severe CNS inflammation because it lacks mineralocorticoid activity. Triamcinolone is useful for local intra-articular therapy due to limited systemic leakage. Dexamethasone penetrates the CNS effectively and has negligible mineralocorticoid activity, making it ideal for cerebral edema. Betamethasone crosses the placenta and is preferred for fetal lung maturation. Beclomethasone, budesonide, fluticasone, and mometasone are optimized for local action with minimal systemic bioavailability. This improves safety during chronic inhalational or topical therapy. All glucocorticoids are not equal. Drug selection depends on the clinical goal. Hydrocortisone or cortisol is preferred for physiologic replacement, dexamethasone for cerebral edema, inhaled steroids for asthma, and betamethasone for fetal lung maturation. This table emphasizes an important clinical principle: pharmacologic design determines therapeutic utility. Corticosteroids must be used cautiously in infections, diabetes, hypertension, psychosis, glaucoma, cataracts, osteoporosis, and immunocompromised states. Infections such as tuberculosis and varicella may reactivate during immunosuppressive therapy. Therefore, patient selection and monitoring are extremely important. Mineralocorticoids primarily regulate sodium and water balance to maintain hemodynamic stability. Aldosterone is the natural prototype hormone. Excess mineralocorticoid activity causes hypertension and hypokalemia, whereas deficiency leads to hypotension, hyperkalemia, and dehydration. A more detailed discussion is done while discussing cardiovascular pharmacology. Fludrocortisone is the most commonly used mineralocorticoid replacement drug. It has potent sodium-retaining activity and is especially useful in adrenal insufficiency. Aldosterone itself is not used therapeutically because of pharmacokinetic limitations. Aldosterone secretion is regulated mainly by the renin-angiotensin system and serum potassium levels. Low sodium, reduced extracellular fluid volume, hypotension, and hyperkalemia stimulate aldosterone release. ACTH contributes minimally compared with the renin-angiotensin system. Mineralocorticoids increase sodium and water retention while promoting potassium and hydrogen ion excretion. Excessive activity may therefore produce hypertension, edema, hypokalemia, muscle weakness, arrhythmias, and metabolic alkalosis. This section of the lecture focuses on pharmacologic interference with corticosteroid function. The hypothalamic pituitary adrenal axis is tightly regulated by feedback. We can suppress adrenal steroid synthesis, destroy adrenal cortical tissue, or block corticosteroid receptors. These drugs are mainly important in hypercortisolism, management of hypertension, adrenal tumors, and hyperaldosteronism. Corticosteroid antagonists can be classified into non-selective steroidogenesis inhibitors, selective glucocorticoid antagonists, and selective mineralocorticoid antagonists. Understanding this classification helps organize a large number of drugs clinically and pharmacologically. Adrenal steroidogenesis begins with cholesterol, which is converted into pregnenolone in mitochondria under ACTH stimulation. This is the rate-limiting step. Pregnenolone then diverges into three pathways color-coded here. Mineralocorticoids as orange, glucocorticoids as green, and adrenal androgens as blue. Key branch point enzymes include 3-beta-HSD, which converts pregnenolone into progesterone, and cytochrome P45017A1, which directs synthesis toward glucocorticoids and androgens. Important downstream enzymes include 21-hydroxylase and 11-beta-hydroxylase for cortisol synthesis, while aldosterone synthase produces aldosterone. Many drugs inhibit these enzymes as shown. Aminoglutathamide blocks early steroid synthesis. Ketoconazole inhibits multiple CYP enzymes. Trilostane inhibits 3-beta-HSD. Metyrapone and osilodrostat inhibit 11-beta-hydroxylase. Abiraterone inhibits 17-cypriot pounds. Mitotane inhibits some enzymes at low doses but becomes adrenal cytotoxic at higher doses and causes adrenal cortical cell destruction. Aminoglutathamide blocks formation of adrenal steroids and was historically used in hormone-sensitive breast cancer. Ketoconazole is primarily an antifungal drug, but at higher doses it suppresses steroidogenesis. Hepatotoxicity is an important adverse effect and requires monitoring. Trilostane inhibits steroid synthesis and mainly causes GI adverse effects. The adrenocorticolytic drug mitotane destroys adrenal cortical mitochondria and causes permanent adrenal atrophy. It is especially useful in adrenal cortical cancer. Metyrapone blocks 11-beta-hydroxylation and reduces cortisol synthesis. Abiraterone suppresses androgen and cortisol synthesis and is important in prostate cancer therapy. Mifepristone is primarily an antiprogestin, but at higher doses it also antagonizes glucocorticoid receptors. Spironolactone is a mineralocorticoid receptor antagonist with antiandrogen effects. It is used in hyperaldosteronism, resistant hypertension, heart failure, and hirsutism. Apluranon is more selective and lacks significant antiandrogen activity. This diagram integrates aldosterone physiology with pharmacologic intervention. This pathway is central to the treatment of hypertension, heart failure, and chronic kidney disease. This integrated clinical algorithm summarizes the entire lecture. Take time and try to understand the logic behind steroid selection rather than memorizing isolated facts. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!